Hello, everyone. Renal denervation has re-emerged as a promising adjunctive therapy for resistant and uncontrolled hypertension. Today, GIS Roundtable Talk will discuss the evidence behind the use of renal denervation in such patients and the indication and the real-world adoption of such technology. Please welcome with me Dr. Siraj Abu Naja and Dr. Nabil Ismail. So I will redirect my question first for Dr. Nabil. How do the most recent trial influence our confidence in using renal denervation therapy?
So, renal denervation went through a long time and extensive number of clinical trials and development over the last, let's say, decade and more. Now, if we want to focus on the most recent clinical trials that got the FDA to approve two of the platforms, now we have the Simplicity trials, which is testing the Medtronic platform, the spiral catheter, and we have the Paradise system that was tested in the Radiance clinical trial program. And they both showed efficacy and safety of using renal denervation as an adjunct modality to treat hypertension and help controlling this modifiable risk factor. And as a result, the guidelines, as a result of those clinical trials, it made it to the guidelines where RDN now received a 2B recommendation in both the American ACC/AHA guidelines and the European Society of Cardiology, as well as the European Society of Hypertension. And we just presented the GIS, the Gulf Interventional Society consensus document based on those clinical trials. So it's very encouraging for us as a practitioner to pursue this modality.
Thank you, Dr. Nabil. Dr. Siraj, what is the proper patient profile for selecting the renal denervation therapy?
Okay, I think this is the most important question in practicing RDN in our population. So you have to be good selection for the patients. You need to have all the criteria to justify doing RDN to improve the outcome and to get the efficacy of the RDN. The most important thing is that the patient's characteristic, which is patients should be on at least 3 medications, including diuretics. The patient should not have low GFR, because it may affect the result of the procedure. The third one, which is the most important thing, is that the patient should be not in targeting blood pressure. The second, or at least I would say alternative option, is the patient's preference, which I think we should put it in our consideration, because if the patient is now going to be adherent to the medications and he's preferring to have the procedure to minimize the medications or get rid of the medications, is one of the major indication right now, and it's mentioned in the guidelines, European Society of Guidelines or American Society of Guidelines, or even hypertension guidelines. If the patients cannot adhere to the medications and he prefer, that should be one of the selecting criteria. Those are the main things that you should focusing on selecting patients who are getting the RDN as a therapeutic tool. And as Dr. Nabil said, this tool is not just, I would not consider it just an adjunctive medication. I think it's just one of the main things of treating hypertension, and it's going to be more growing and growing. The trials are amazing in the results in terms of efficacy and safety. So we should at least push to do more cases in terms of treating hypertension patients, because as we know, the hypertension is one of the leading causes of stroke, heart attacks, death, and is the most common cause of death as a risk factor for cardiovascular events in the world. Selecting the patients with the proper criteria that's mentioned on all the guidelines and mentioned also in the GIS consensus of treatment of hypertension is the main thing to start the procedure.
And this give me, I would like to elaborate more about the red flags characteristics that makes you hesitant to use it?
I think one of the main red flags that hesitant to use is not, first of all, is not the patient's selection criteria. If the patient is not taking the proper medications. The second thing is if the patient thinks that it's a cure for hypertension. Because I always tell the patients there is nothing called cure for hypertension either by medications or by procedure. It's not about the procedure itself will cure or the medication will cure this. You have to live with this disease, and we are doing our best to help these patients in terms of medications or procedure-wise. The second thing is, if everyone agree with me that if there is a patient with renal stenosis or signs of renal artery stenosis, that should not be considered as a part of the treatment. I think those are the main things I should consider. Even at the GFR is from the recent trials, Radiance or Simplicity trials, show that it's safe even if the GFR is at least above 40. So the procedure itself is very, very promising. Results are amazing, efficient, and the side effects are minimal. And it's easy to use.
Yes, it is easy indeed. Dr. Nabil, how do you think the advancement in the technology of the ablation catheter has improved the outcome and effectiveness of the therapy?
Yeah, so the old technology, which was called Flix catheter, it was partially effective in doing this, but it was one of the reasons why HTN3 actually failed to show a difference as the first randomized controlled trial. And that's why, although it caused a setback in the progression of renal denervation adoption in our community, however, it opened our eyes to investigate more.
Yes.
And cadaveric studies have shown that some of the nerve fibers, they join the renal artery after the first bifurcation of the renal artery. So as a result, a lot of investigation and design, change in the design of the catheters to mitigate that problem. And there are, as I said, two approved by the FDA, two cleared technologies. So the radiofrequency ablation catheter, which is made by Medtronic, it's a spiral catheter, so it takes the shape of the vessel. You need a vessel between 3 to 8 millimeters. As long as the vessel in that size, then you should go and ablate it. So you target the main vessel and the branches as long as they are outside the renal parenchyma. And the other approved modality by the FDA is the ultrasound-based renal denervation, which is basically a balloon catheter where you have to select it in a size where it's one-to-one matched to the renal artery itself, and then sonicate that area. And that gives you, the beauty of this device is that it will give you a 360 degrees of ablation at the whole circumference of the renal artery, which makes it more robust in terms of ablating that segment of the treatment. But for this modality, which is made by Recor, it's called the Paradise system. It is recommended by the manufacturer to treat the main arteries, not into the branches, and it is recommended to do 2 to 3 per side. So on the right side, you do 2 to 3 distal, mid, and proximal, and as you do the same in the other side. So those are the US FDA approved technologies. Now there are other modalities that are in the pipeline coming, and there are devices that are made by other companies, but they are still investigational. For now, we have those two devices.
So I think we can conclude that the new technology of the new catheter and the need of more patient recruitment, I think, as before we started the discussion, some people they are saying it's just class 2B indication, the guideline. So how can we convince the people to use such technology or consider it in their practice?
So we need to make people, and when I say people, both the practitioners as well as the public aware of this technology as an effective and safe procedure that will help in treating these patient populations. So awareness campaign to target the physicians and healthcare practitioners about those. And it is challenging, to be honest with you, but now once we have this FDA approval, actually we can see that there is actually a rise in the number of cases that are being done locally and also internationally. Even in the US now, the number is really going really steep, in a steep curve. And initial results of the registry data are very encouraging. So as long as we set proper expectations, as Dr. Siraj said, it's not a cure, but it helps. It helps a lot. If you reduce the blood pressure by 10 millimeters in systolic blood pressure, regardless of your target, so if your baseline is 160 or 150 or even 180 or 140, if you reduce that by 10%, 10 millimeter of mercury, that will be reflected on major adverse cardiovascular events, on stroke events, and even on mortality. So the lower you go, the better, regardless of the modality you use.
Okay, thank you, Dr. Siraj. Thank you, Dr. Nabil Ismail. We conclude today that the RDN therapy is a promising adjunctive therapy for resistant and uncontrolled hypertension. See you, inshallah, في next podcast with GIS Roundtable. Thank you. مرة تسلم.